Welcome to this deep dive. Today, we're tackling a really crucial area for primary care, Major Depressive Disorder, MDD.
Right. And it's more than just feeling sad, isn't it? It really hits a person's quality of life, their relationships, work, education.
Exactly. And unfortunately, it increases the risk of suicidal behavior. So effective management, especially right here in our primary care settings, is just so vital.
Absolutely. And, the 2023 National Mental Health and Well-Being Strategy really emphasizes boosting primary care's role here.
Yeah, which is why we're focusing today on clinical pearls for you, our family medicine residents, drawing from evidence-based guidance for managing MDD in adults.
Sounds good. How are we going to approach this?
Let's make it practical. We'll use a role-play scenario. Imagine your patient, Sarah Tan. She's 35, a financial analyst. She comes in saying something like this.
Okay, I'm ready. Let's hear it.
Doctor, I've been feeling really down for the past month or so. I just can't seem to enjoy anything anymore, and even simple tasks at work feel overwhelming. I don't know what's wrong with me.
Okay, Miss Tam, thanks for coming in and sharing that. Sounds like things have been really tough lately. You said down. Can you tell me a bit more about that feeling? When did it really start?
It's been about a month, maybe a bit longer, like 4 or 5 weeks, and it's pretty much constant. Most days, all day, just this heavy feeling.
Okay, a constant heavy feeling for over a month. And how has your sleep been during this time? Any trouble falling asleep or waking up or maybe sleeping too much?
Oh, sleep's been awful. Yeah, I struggle to fall asleep, and then I wake up around like 3 or 4 a.m. and just lie there. So I feel exhausted all the time, even if I technically got some hours in.
Right, that sounds draining. What about things you usually enjoy? Hobbies, seeing friends? Have you lost interest in those?
Yeah, definitely.
Yeah.
I used to run most evenings, loved it.
Mm-hmm.
Now, just no energy, no motivation. My friends ask me to do stuff, but I keep finding excuses. I don't feel like being around people.
Mm-hmm. And have you been having any feelings of, say, guilt or feeling like you're worthless?
Guilt.
Yeah.
A lot. Especially about work. I feel like I'm dropping the ball, letting my team down. I keep making silly mistakes, and that just makes me feel worse, like I'm not good enough.
That sounds really hard to carry. You mentioned feeling exhausted. Is that low energy pretty persistent throughout the day?
Completely. It's like wading through mud.
Yeah.
Everything feels like a massive effort.
Okay. And how's your concentration? At work or even just reading or watching TV?
Terrible. My mind just wanders. I can't focus on reports, emails. Like I said, the mistakes are piling up. It's so frustrating because I'm usually really sharp.
Understood. Any changes in your appetite? Eating more or less? Noticed any weight change?
Appetite's definitely down. I'm not really hungry most of the time. I think I've probably lost a bit of weight, but I haven't checked.
Okay. Sometimes when people feel this way, they might feel physically restless, agitated, or the opposite, kind of slowed down. Have you noticed anything like that? Maybe feeling more irritable?
Irritable, yeah. My poor roommate, little things she does just really grate on me lately, things that wouldn't normally bother me at all.
Okay. Miss Tan, I need to ask a difficult question, but it's important. Have you had any thoughts that life isn't worth living? Or any thoughts about harming yourself?
Sometimes, yeah, when
Yeah.
things feel really, really bad, I get these like fleeting thoughts that maybe it would just be easier if I wasn't here. But it's not like I've thought about how or anything. I don't think I'd ever actually do anything. It scares me when I think that way.
Thank you for telling me that, Sarah. I know that's not easy to talk about, and it sounds frightening. It's really important you shared it. You mentioned work is suffering. Can you tell me a bit more specifically how this is impacting your job?
Well, I'm behind on deadlines for this big project. I'm worried my boss is noticing. I'm scared about my performance review. Even about keeping my job, when I'm honest.
Okay. And socially, you mentioned avoiding friends. How is that making you feel overall?
This makes me feel more alone,
Yeah.
isolated. My family's all overseas, and I'm not super close with my roommate. So, yeah, pretty isolated.
Are there any particular stressors going on right now that you think might be contributing to this?
Work is definitely a big one. The hours are crazy. It's high pressure, and this project is huge. It's just relentless. And not having my family nearby for support makes it harder, I guess.
Right, that sounds like a lot to handle. Have you ever felt like this before for this length of time?
No, never this bad. Nothing like it.
And have you ever had times where you felt the opposite, like unusually high energy, needing very little sleep, thoughts racing, feeling on top of the world?
No, definitely not, ever.
Okay. Any other medical issues I should know about? Any medications you take regularly, even over-the-counter ones? Any allergies?
Nope, no medical problems. Don't take any regular meds. No allergies either.
And what about your family? Any history of depression or other mental health conditions?
My mom
Yeah.
She had depression when she was younger, maybe a teenager. My dad has high blood pressure, but that's it, I think.
Okay. Sarah, earlier you asked if this is just stress or something more. What are your main concerns right now, and what were you hoping we could achieve today?
I just, I don't understand why I can't just shake this off, you know? Is it just stress? Or is something really wrong? I'm worried about my job, like I said. I hate feeling like a burden. These feelings just scare me, I guess. I just hope you can help me understand what's happening and find a way to feel more like myself again.
Thank you, Sarah. I really appreciate you opening up like this. Just based on our conversation, I've noticed you seem quite subdued today, and your eye contact wasn't always consistent. Your speech seemed a little slowed down at points, and I can see this is bringing up a lot of emotion for you.
Quietly. Yeah,
Okay, let's pause the role play there. For our residents listening, this is a very, very common presentation, isn't it?
absolutely. Sarah's story really highlights how MDD often shows up in primary care.
Mhm.
And notice how the systematic history, using SIGCAP, sleep, interest, guilt, energy, concentration, appetite, psychomotor, suicidality, really helped cover the bases.
It's such a useful framework, and the suicidality questioning, it has to be direct but sensitive. Acknowledging her fear around those thoughts is key. Her saying she has no specific plan or intent is crucial for our initial risk stratification, but it doesn't mean we ignore it.
Not at all.
Yeah.
And the focus wasn't just on if she had symptoms, but how they're impacting her life, the functional impairment, her struggles at work, pulling back socially that tells us this is more than just a bad mood. It's significantly affecting her functioning, suggesting at least moderate severity.
Exactly. And exploring those psychosocial stressors, the demanding job, the lack of local support gives us context. These might be triggers or things that make it harder for her to cope.
Another really critical point you touched on was screening for mania or hypomania.
Mm.
We absolutely have to ask about that before even thinking about antidepressant monotherapy, right?
Mm.
To rule out bipolar disorder.
Crucial, because prescribing an SSRI alone to someone with undiagnosed bipolar disorder can potentially trigger mania. Sarah denied any history, which is reassuring and guiding initial treatment.
And your observations during the MSE part, the subdued affect, slowed speech, tearfulness to a art, they all fit the picture of depression.
Right. So putting it all together, the duration, the cluster of SIGCAP's symptoms, the clear functional impairment, it strongly suggests a moderate major depressive episode. Her PHQ-9 score would likely fall in that 10-14 range, maybe higher.
Okay, so based on that likely diagnosis, what are the next steps? How do we start thinking about management?
Well, the foundation is always that therapeutic relationship, making Sarah feel heard, validated, and building trust. Shared decision-making is paramount. She needs to be involved in the plan.
And psychoeducation is huge, isn't it? Explaining what MDD is a treatable medical condition, not a weakness, addressing that stigma she might feel.
Absolutely vital. And alongside that, we discuss practical lifestyle stuff, sleep hygiene strategies, encouraging even gentle exercise like a short walk, looking at ways to manage that work stress, maybe setting boundaries.
Then we get to specific treatments. The guidelines often point towards psychological therapy first for mild to moderate depression, if it's available and acceptable.
Yes, for someone like Sarah, with likely moderate MDD, offering psychotherapy like CBT, cognitive behavioral therapy, or IPT, interpersonal therapy, is a really good first-line approach. CBT helps challenge those negative thought patterns and behaviors, while IPT focuses on relationship difficulties that might be contributing. Supportive counseling can also be helpful.
But what if therapy isn't practical right away? Maybe long wait lists where she's just not ready for it.
That's a common scenario. In that case, or if her symptoms were more severe or she preferred medication, we discuss starting an antidepressant, usually a second-generation one like an SSRI, escitalopram, sertraline, fluoxetine are common starting points.
And if we go down the medication route, what's crucial to tell her?
Managing expectations is key. Explain it takes time, often 2 to 4 weeks for initial improvement, maybe 6 to 8 weeks for the full effect, and discuss potential side effects reassuringly but honestly. Things like initial nausea or headache, though often temporary.
And given those fleeting suicidal thoughts she mentioned, safety netting needs to be really solid.
Absolutely critical. Clear instructions. What to do if she feels worse, if those thoughts intensify or become more frequent, or if side effects are intolerable. Providing contact info for helplines, emergency services, maybe online resources like MindSG or MindLine. Letting her know she's not alone and help is available 24/7.
And follow up? How soon?
For a new diagnosis, especially moderate with any suicidal ideation mentioned, you'd want to see her back relatively soon, probably within 1 to 2 weeks. Check in on symptoms, side effects if meds were started, and definitely reassess suicide risk.
Using something like the PHQ-9 again at follow-up can be helpful too, right? To track progress objectively.
Yeah, the PHQ-9 is a great tool for monitoring symptom severity over time. Helps guide treatment adjustments.
Okay, that covers the main management principles. Any other key clinical pearls specific to this kind of presentation?
Yes, one really important one we shouldn't forget. Given her symptoms of fatigue and maybe some weight loss, it's wise to do some basic blood tests initially, just to rule out organic causes that can mimic or worsen depression.
Like what specifically?
A TSH to check thyroid function hypothyroidism can certainly cause fatigue and low mood, and a full blood count, an FBC to check for anemia, which also causes fatigue. Basic, but important to exclude.
Excellent point. Always keep potential medical mimics in mind. So let's quickly summarize for our family medicine residents listening.
Okay.
When a patient like Sarah presents, remember, a thorough SIGCAPS history, sensitive but direct suicide risk assessment, assess functional impact, explore stressors, screen for mania hypomania, rule out organic causes with basic labs like TSH and FBC.
Then build rapport, use shared decision-making, offer psychoeducation, discuss lifestyle, consider psychological therapy first for mild, moderate cases if feasible.
If using meds, explain the timeline and side effects clearly. Crucially, implement robust safety netting, especially if any suicidal ideation is present. And arrange close follow-up, maybe within 1–2 weeks initially, using tools like the PHQ-9 to track progress.
Exactly. Remember, your role in early identification and management and primary care makes a huge difference in people's lives. Don't hesitate to use resources like the ACE clinical guidance to support your practice.
Thanks for joining us on this deep dive. We hope walking through Sarah's case was helpful. Recognizing and managing MDD effectively is truly a cornerstone of great family medicine. Keep learning, keep supporting your patients.